Hello, I'm Dr. Candice Castro, a general surgeon at the Academy of Health Sciences Physician Assistant Branch. I'm going to show you how to suture an uncomplicated laceration using a model of the forearm. Assisting is Chief Warrant Officer Tom Milliken, an orthopedic physician assistant.
Let us assume that it is appropriate to close the wound with suture. That is, the wound is fresh and clean rather than several hours old or heavily contaminated. Remember, animal scratches and bites, or wounds that are sustained in the field around machinery or tools, and all combat wounds are generally considered to be too contaminated for primary closure. Wounds that have been closed are more likely to become infected than wounds that have been cleaned and dressed open. If you are instructed by a surgeon not to close a wound, it is not because of your technical skills, but because he considers the wound to be too contaminated and therefore more likely to become infected. Let us also assume that you have already cleansed the wound and its surrounding area. If the wound involves the forearm, for example, first the entire forearm, including the hand, is cleansed, and a local anesthetic is injected around the wound. Then the wound itself is inspected in order to remove all foreign bodies, that is, all the glass, grass, gravel, grease, dirt, paint, or whatever else is present. Loose skin and fat are also debrided. Then the wound is irrigated, preferably with sterile saline, but clean drinking water will also do. The area immediately surrounding the wound may be painted with an antiseptic, but there is no need to put antiseptic, peroxide, alcohol, or any other agent directly into the wound. Don't try to substitute these agents for proper debridement and cleansing. After sterile draping, you are ready to suture the wound. It is helpful if you have pickups, needle holder, and scissors, as well as appropriate suture. For a simple skin laceration, generally, monofilament, non-absorbable suture is appropriate. If you do use subcutaneous suture, an absorbable suture is best. We'll use 4-0 nylon on a cutting needle for this wound. It is important to look at the package to see the size and the type of suture, as well as the size and the type of needle. A cutting needle is preferable for use on skin. A taper needle does not easily penetrate skin and should be avoided. Load the needle on the needle holder about halfway along the needle. Some will tell you to load the needle closer to the tip. Others will tell you closer to the back. If you load it in the center, you will probably please everyone. Load the needle with the sharp end pointing up. Pay attention to how you hold the needle holder and other instruments. The ring finger goes in one side of the instrument and the thumb in the other. The index finger remains free to steady it. Holding the instrument between thumb and index finger is not correct. Don't do it. This is the correct way to hold the instrument, with the ring finger and thumb in the handle and the index finger free to steady the instrument. Insert the fingertips only up to the first joint. Now for the pickups or thumb forceps. Hold them like you would a pencil, with the hand below the instrument like this. Don't hold them with the hand above the instrument. Now you are probably thinking, I have always held the instruments my way and no one has ever corrected me before. Also, I'm used to my way and would be uncomfortable doing it any other way. Anyway, who cares how I hold the instruments as long as I get the job done? What if I were a novice carpenter and were going to demonstrate how I hammer in a nail?
I've always held the tools this way and nobody's ever corrected me before. It would be uncomfortable for me to hold the tools any other way. Anyway, who cares how I hold the tools, as long as I get the job done?
Surgeons hold instruments this way, and they do this for a living. There must be a reason why they do it this way. It is more comfortable to sew toward yourself. That is, start at the far end of the incision and work back towards yourself. Now hold the needle holder with the tip of the needle and the palm facing down. Pretend that the needle is straight rather than curved and push straight down into the tissue to the desired depth. Then slightly turn the wrist as though you were turning a doorknob. If you are taking 2 bites, let go of the needle and re-grasp, keeping the palm facing down. Avoid grasping the needle with your palm facing up, as this will make it hard to turn the wrist in a smooth and natural manner. Insert the needle into the opposite side of the wound at the same depth as the first side. Note that it's not always necessary to hold the skin edges with the pickups. If you do use the pickups to hold the skin, use them gently rather than leaving rat tooth marks in the skin. Also, it's not usually necessary to steady the needle with the pickups. After completing the stitch, it's time to do the instrument tie. The suture forms a V shape, with a long end having the needle and a short end. Hold the long end in one hand and the needle holder in the other. Insert the needle holder into the V. On the first throw, wrap the long end of the suture twice around the instrument toward the short end. Take the short end of the suture with the needle holder and pull it to the other side, watching the throw go down flat. Once again, you have a V with a long end and a short end. Again, insert the instrument in the V. For the remaining throws, wrap the long end once toward the short end, take the short end and pull it to the other side, watching the knot go down square. Here's the V, instrument in the V, wrap the long end toward the short end, grab the short end, pull it to the other side. Instrument in the V, wrap the long end toward the short end, grab the short end, and pull it to the other side. Notice that your hands will cross and uncross as you perform these square knots. For nylon or other monofilament suture, perform 4 or more square knots, leaving no daylight between the knots. You want the knots to be tight and square, but you don't want to crush the tissue with the suture. Imagine that you have a dog to walk, but no leash, so you're going to use a rope as a leash. When you tie the rope around the dog's neck, you want the knot to be tight and square so that it won't slip, but you don't want to choke the dog. When you are suturing and your instructor says, "Don't choke the dog," he means that you are crushing the tissue with the suture. Here is a wound that has been closed with the correct tension. Here is a wound that has been closed too tightly. This is a series of simple interrupted stitches. The simple interrupted technique is suitable for almost any wound. Here is a wound closed by a simple running or continuous technique. Now I will show you the vertical mattress technique, which is used to ensure that the edges of the wound will evert or turn outward instead of turning inward. Start the stitch the same way as for a simple interrupted. Before tying the knot, turn the needle around and go straight back to the other side of the wound, catching just the very thin edge of the wound on each side. Then tie on the side of the wound that you started on. Notice how this everts the skin edges so that they don't cave in. This technique is especially useful for deeper wounds in which you fear there will be dead space. Another technique is the running subcuticular, used for very clean wounds in areas of cosmetic importance such as the face. Be sure to use a cutting needle rather than a tapered. For purposes of this demonstration, black silk will be used for better visualization. When using absorbable suture, one end is anchored near one end of the wound and brought out at the very tip of the wound, but not through the outer skin. If necessary, use the pickups for better traction on the skin. Guide the needle parallel to the skin, just under the surface, that is, in the subcuticular area. Notice this is not as deep as the subcutaneous layer where there is fat. After the first stitch, start the next one directly across on the other side of the wound. Continue in this manner to the end of the wound. There are a number of ways to secure the end of the suture. Remove the needle holder, leave a loop at the end of the suture, then insert the adjacent suture partway through, creating a second loop. Tighten down the first loop. Then insert the needle in through this new loop and tighten it down. Replace the needle on the needle holder and carry the stitch through the very tip of the wound, from inside the wound to some nearby site outside the wound. Cut the suture so that there is none protruding from the wound. This procedure can also be performed using monofilament, non-absorbable suture, but it must be anchored outside the wound and later removed by cutting the anchoring stitch and pulling on the opposite end. Shallow wounds can also be closed using special tapes. Preparation and cleansing of the wound is the same as for suturing the wound. First, dry the skin edges and possibly degrease with alcohol. Remember, alcohol does not go into the wound itself. Keep a sponge handy so that any blood or serum from the wound will not wet the area. Use a pickup to handle the tape to avoid getting blood and powder from your gloves on the tape. Pull the skin edges together as you secure the tape. Dress the wound with a small dressing and tape. Wound cleansing is more important than suturing. Wounds that are closed are more likely to become infected than those that are cleansed and dressed open. If you are unsure as to whether or not sutures are indicated for a certain wound, remember, when in doubt, leave them out.